sleepy night to all. Myself, Ajay Pratap Singh. I'm going to present my case of foreign body migration. It's salvage and the complication of stent thrombosis. So this is my case, a 44-year-old male who presented to our emergency with acute onset chest pain, ECG suggestive of ST elevation in diffuse ST depression in all the leads. Troponin was positive. Echo showed moderate LV dysfunction with EF of 40%. Previous history, the patient underwent angioplasty 8 days back on the background of NSTEMI. Right coronary artery was the culprit lesion, stented with 3 stents of size 4, 3.5 and 2.75. The patient was compliant with DAPT. However, the procedural shots were not available. And notes showed there's no mention of any kind of complication that occurred during the procedure. As the patient was in heart failure, cardiogenic shock, CLIP class 4, we planned for an high-risk PCI, keeping in mind that the acute stent thrombosis is the likely cause of this event. So this is the baseline angiogram. Left coronary artery was normal. We can clearly see there was metallic RCA, and in the second shot there is evidently there was something present in the proximal part of the stent. There was something mysterious that was radiopaque in the proximal part, which was clearly seen in the alveocaudal view also, alveocranial view also. We can clearly appreciate a mysterious dot in the proximal part of the stent. So, fearing the only complication which we knew, we took the shot of RCA. RCA was a high anomalous origin. We took the shot, and to our misery, it was 100% as expected at the point of the mysterious foreign body or the mysterious dot that was present. Immediately, the lesion was crossed with pilot 150 wire after facing a bit difficulty, and a POVA was done with a 4.0 balloon. Considering the hemodynamic situation of the patient was critically ill. I mistook. I didn't saw where the mysterious foreign body was. I did POVA. I took the wire out, planning to take the patient out from cath lab. And to my misery, when the shot was taken, it is clearly evident that the foreign body which was present proximally in the stent has now migrated distally, probably due to the POVA done at the next event. Now what to do? The patient was sick, hemodynamically unstable, so I decided to abandon the procedure here as I have achieved V3 flow, planned for to take some time, stabilize the patient, and after that we'll be doing something. After 1.5 days when the patient was stable, again intervention was planned. This time I hooked it with an MPA guide, femoral access. But to my despair, field FC wire, there was clearly buckling at the foreign body side. I was not able to negotiate a field FC wire. Following that, I switched to a parallel wire technique with a CTO wire that is crossed at 100. I again failed to negotiate across the mysterious foreign body. After that, we deeply intubated the guide, there were balloon support, and that too also I failed to negotiate across the foreign body which was present. Then, trying an CTO approach of dissection retentory, I took Corsair along with Conquest Pro 12-gram balloon wire. However, I was not in the distal lumen. What to do? Eventually try again, and I succeeded with Corsair and pilot 150 wire. Eventually, I crossed the mysterious foreign body. Now started the saga of balloon dilatation. Nothing was passing across that mysterious foreign body. Eventually, a low-profile balloon of 1.0 size passed, it dilated, and then subsequent sequential dilatation of balloon was done. Adding to the misery, all semi-compliant balloon ruptured at that point, and finally an NC balloon of 2.5 gave away the way. Following that, we did an IVUS of that foreign mysterious body to understand what is that thing and what is the pathology. There was severe underexpansion of the distal stent that was the cause of the enlargement of the foreign body. We can clearly see. However, then we co-registered with angiography to see what is the foreign body. This is the best image which we can acquire. There was something present at 2 o'clock. Following that, now what has to be done? What I thought I did, I implanted a graft master of 2.75 millimeter, plastering the foreign body which was present between the membrane of the graft master and the previously implanted stent, so that now the foreign body is plastered. It will not move forward or backward, and there will be no compromise of the lumen also. Following that, this is the angiographic view. We got a TV3 flow. Following that, we did an IVUS optimization of the graft master, dilated, reached a MLA of 9.43 and 10.35 in the graft master, which was acceptable. This is the final angiogram after the procedure. There was TV3 flow. However, there was distal lesions. I thought the patient will live for another day, then we'll fight for that lesion. That was distally. Recently, I have done this procedure also with a DEB. And these are the final IVUS images which showed adequate, good luminal gain. And opposition, what is the take-home message? In this case, we have showed a novel technique of salvaging a patient using a graft caster. Foreign body entrapment is an inherent risk of angioplasty and carries high mortality if left unattended. Micro snare technique, which manipulating a snare in such metallic RCA was a challenge where wire was not crossing, so we didn't try micro snare. Subintimal approach was used, which I failed. We used modified Fogarty technique, attempted with a 2.0 balloon at 10 atmosphere pressure, but failed despite sustained traction and fear of wire loss and stent deformation also. Surgical retrieval is always an option, but it is time consuming and hemodynamic conditions were not favorable. What are the learning from this case? Foreign body entrapment is rare. Under expansion of drug-eluting stent can lead to difficulty in negotiating the wire across the foreign body, for which we should be ready with techniques applied in CTO interventions. That is microcatheter support, hydrophilic wire, dissection and re-entry. Modified Fogarty technique should be used in such cases where entrap body is small and distally dislodged. We can also use a forward Fogarty method also. However, I failed to recollect at this time, so I didn't try forward Fogarty. A covered stent can also be used when in doubt of further migration of the entrapped foreign body. And prevention is always better to avoid entrapment, avoid undersizing, dye dilution, lesion preparation in calcific and tortuous vessel, and avoid reusable hardwares. Thank you. So, most probably it seems like that was a tip of a broken microcatheter in the first procedure, and the operator tried to bury that with using an additional stent in the proximal segment.
Yeah, this is probably working. So microcatheter tips, especially a corset tip, is something which is a possibility. The second thing is that sometimes balloon itself is too big. You know, what happens is the balloon marker can come out. And the third thing possible is that the tip of the guide catheter itself, when you remove it, gets sheared off, and that can go down, and that you had in wiring it, because it went down from proximal to distal. So it was not something very big. It's unlikely to be a balloon because it will not travel from there to here. So the tip of the microcatheter, and imagine something which is cylindrical, and if it is aligned with the vessel, it's okay. But if you inject something and it becomes a little at an angle, then you will not be able to cross. Right. So a plain stent, even a DES, would possibly have been adequate to exclude this. You need not have used a covered stent, because now the potential for restenosis has become very high, and stent thrombosis.
This might be a guide tip, because it's very difficult to expand also.
So I felt that it was a guide tip, and see, it's a cylinder. And because it's a cylinder, it's gone there, and once you've pushed it down, it does not remain cylindrical. The cylinder tilts at an angle, and therefore the wiring became such a challenge. I would not have used a graft master.
What I thought was that the previous operator has already tried a stent to bury that thing in proximal segment. Repeating the same thing again will be repeating the same mistake that earlier operator has done. So my concept was I have to save this patient definitely. I don't want forward migration. I don't want to take this out because I was not able to take it out. So what definitely could have been done was to plaster it between the membrane of the graft master and the stent. Now neither it is going to protrude in the lumen, thinking of that, and now it will not migrate forward also. However, a stent can also would have been used, or a forward Fogarty method can also be done. But at that time of moment, I was the only operator there. What I thought was definitive, and I did that.
If this was the tip of the guide catheter which had broken and was lying here, once you pushed it down and it goes down all the way here, it becomes at an angle. Otherwise, why were there so much of difficulty? If something which is getting pushed down with a hydraulic injection, why are you unable to access it? Sorry. It is because now in the same vessel, this has become a little angulated like this, and therefore it becomes difficult to cross. So that is why I think it is the tip of a guide.
I'll add that it was not pushed by the hydraulic pressure of the die. I did COBA with a 4.0 balloon proximally at the side of the
whatever
side,
it is,
and
it's got pushed down.
Balloon can be easily pushed by other balloon, but this will not expand. That's the problem. And that's why you had so much difficulty passing smaller balloons, and you have to go very high pressure.
I'm just very impressed you got a graft master that far down through the stent, so that was a good job, because it's not very deliverable.
But looking at the distal flow, I think we could have left it also.
Sir, I thought of leaving. I thought of leaving also, but then it was very intriguing what it is. So that's why I stabilized the patient and took the patient again. And I have already done the stage procedure of distal RCA. The patient is doing well.
Artwork, my Picasso moment here.
Why don't you sign that and we'll auction this artwork? We'll auction the artwork. A rupee, 1 rupee.
Sir, good night all.